We'll go on to the next paper, the clinical outcome of anorectoplasty performed in the first 6 months of life for high anorectal malformation by Dr. Lee.
Good. Dear Chairman, ladies and gentlemen, thank you for giving me the opportunity to share my preliminary research report. I'm from Wuhan Union Hospital. Anorectal malformation. Anorectal malformation are relatively common congenital anomalies. Although many advances in the management of these patients have been achieved during the last 30 years, a significant number of these patients still suffer from incontinence, constipation, and sexual inadequacy. So I agree with Pina absolutely that anorectal malformation represents a continuing challenge for pediatric surgeons. According to the results that we have been achieved for a newborn with a high anomaly, the processing framework is clear. According to the doctor's experience, we can choose 1-stage, 2-stage, or 3-stage procedure. But we have little knowledge about what is the optimal interval between the steps. So we proposed a project to verify a potential advantage of early repair of high ARM and to detect the potential mechanism. According to the age at repair, 44 cases with high ARM were divided into 2 groups. They underwent a colostomy plus lap procedure. The facts were the follows. The anorectal functions was evaluated by Kelly score system. My entry nerve plexus, BCL2, and the Bex protein of the resected terminal rectum were detected. The mean the mean follow-up time was 70 months, with a range from 24 to 108 months. Patients younger than 6 months underwent anorectoplasty have a better total Kelly score. More plexuses contain ganglion cells. More BCL2 protein expression and less Bex protein expression. Discussion. Bowel control has a complex mechanism. Besides many congenital reasons, external factors, for example, repair techniques, repair timing, and bowel management after repair is also important. This study was focused on repair timing. Prolonged colostomy can lead to chronic ischemia, dilation, dysmotility dilation circle, missing the acquired local sensation and psychological sequelae. These factors eventually affect bowel incontinence. Early definitive repair was suggested by Levitt and Pina. They agreed that the early repair has advantages, including less time with abdominal stoma, less size discrepancy, easier anal dilation, psychological sequelae, and acquired local sensation. Anorectoplasty after 6 months would cause lower distribution of ganglion cells, decreased the expression of BCL2 protein, increased the expression of Bex protein, and lower total Kelly score. Combining findings in this study, we can conclude that the early definitive repair younger than 6 months may achieve better anorectal function. Nerve degeneration caused by the apoptosis of ganglion cells in myenteric nervous plexus may play an important role. Okay, it's a preliminary research, and there are some drawbacks in it. Anorectal sphincter squeeze could be evaluated by an anorectal manometry. The results can be more objective. Moreover, quantitative research and further study is needed. Thank you for your attention.
Any questions? I just want to make a comment. Usually for anorectal malformation, we usually prefer to do the surgery, either it's high or low, before 6 months, because we know the cerebral anal reflux is better functions at 6 months of age. So did you notice that in the other groups in your practice?
Yeah, in fact, we did the groups we divided more accurate from younger than 3 months, and 3 months to 6 months, okay, and 6 months to 1 year, and older than a year. But it's more complicated in static analysis, so I'm not
not shown in this presentation. Okay, thank you.
But in my study, I got the preliminary result is in the first 2 groups, younger than 6 months and 6 months to younger than 3 months and 3 months to 6 months, they get the same result.
Okay.
Okay, thank you.
Thank you.